Dr. Stanford, Dr. Boyle, from Spain, from Pamplona, Spain. Entonces, vamos a empezar con...
Going to start with Álvaro Ruiz Zambrana. We have two very interesting questions because we have a general audience and specialized audience. Let's start with a question. There are people who ask that sometimes the natural methods, it's hard to make the recognition. And these are two questions in one. One, what is the role of the LH stripes in these tests, sticks in this self-help program? How should they be used or not? It's not the same. A country with difficulty in order to obtain it. It's expensive due to the price. When to do them, when to determine the most efficient method. That's the first. The legend of the dual ovulation. I was pregnant because I ovulated 1 week later after the peak. Can the woman of the human species ovulate later and become pregnant? This could somehow unstructure the whole concept of the natural fertility awareness. Well, the first question as to the ovulation tests, well, personally, I don't like them too much. I like more to recognize the fertility indicators. That interpretation is better, but it's a help, nevertheless, for those who have difficulties at the beginning, or if they want to confirm ovulation. When to do it? Well, it depends on each person, each woman. There is no length of exact cycle length. That woman should look at the length of her cycles, prior cycles, and more or less calculate based on that. In a normal cycle, 28, 29 days, she will start doing them around day 10 of the cycle, every day until detecting the peak of ovulation between 1 or 2 days before ovulation, assuming this around day 15 or 16 of the cycle. The ideal thing, in order to not to be late, is to start doing that around day 10 of the cycle. And I don't like it as a single determination. There are many people who come to my office without having coming before, but they have bought this ovulation test, and it's frequent that they use it in the wrong manner because they have read in the instructions somewhere that that test is telling them the 2 most fertile days. They don't have relations until the test is positive. If they do it too late, they come too late. Well, I don't like it because it can be confounding many people. It can be confusing for many people. And as to the dual ovulation, it's funny because I think about some people who have asked that in the past as well. And I believe that if you have been careful with the different lectures we've given, that it's quite evident that this doesn't happen in human species unless it happens at the same time. This is an exceptional situation. Sometimes in the woman, they ovulate twice, but at the same time, these are twins of 2 different ova. But during the rest of the cycle, this doesn't happen. If a woman has ovulated once, she's not ovulating again. What can happen is the first time, as Dr. Donoso has shown in his presentation, she has a mucus evolution that seems to be a fertile mucus, but in reality is not ovulating. And in reality, the woman is trusted because she thinks she has ovulated, but she is ovulating later, but not in a dual one, because the first time she didn't ovulate. I don't know if this is clear for you now. It happens that in the human species, when we have an obvious ovulation, the door of the cervix is closed, and the mucus becomes gel, and it adopts it's the main role. Although there could be a later ovulation, it wouldn't be efficient. Thank you very much, Dr. Ruiz. Are you listening in English, Dr. Boyle, Dr. Stanford? Are you listening to us? Are you receiving a translation? All right, we will be going on speaking in Spanish. One question for both of you. Well, I thank you both for being here and with us. One question for Dr. Stanford from Dr. René Leiva. There is another question that is similar, so I put them together, those two questions. Dr. Leiva talks about a problem. How do we face the lack of randomized trials and controlled trials in order to prove the effectiveness of the natural methods? And associated with this question, I want to link it with another one that says, what would you suggest, Dr. Stanford, in order to be able to collect adequately the information, the registries that the different centers where they teach natural methods in order to be able to make adequate research? What are your suggestions that you could give us here to the panel?
May I ask you the second question? May I ask you to say it one more time?
La segunda pregunta es,
Yes, the second question is, what do you suggest that the centers of instruction or teaching of natural methods, how can we collect adequately the registries in order to be able to give this information translated into research?
Okay, thank you. So the first question about randomized trials, I will just say it is difficult to do an appropriate, reasonable and ethical randomized trial in family planning because women want to choose what method they use. And, you have to have women and couples who would be willing to use either method to randomize them to one method or another. I don't think it's impossible, and I think it could be looked at. But, and so I think we should have some innovative thinking about that, especially. So I would, as far as randomized trials, I would suggest looking at one randomized trial that was done by Richard Bering. It was published 2008 or maybe 2012. I have to go, but it was a publication by Richard Bering of a mucus method versus the monitor method. However, that trial is not perfect, and it actually shows some of the problems in conducting a trial. I won't get into them right now, but if you read the paper and want to talk to Dr. Bering or myself, you can see some of the trial had some difficulties, and so randomized trials are possible, but have to be thought out very carefully. Now, in terms of data to collect, I think that any natural family planning or fertility awareness-based program that wants to do a good job of collecting data so that it could be used for research. I think there are some centers that do this routinely, and I think one of them is PROCEF in that I've seen in visiting the University of the Andes, but there are others too. But I think so that you should sit down and look at some of the recommendations about studies. I'm biased, so I would say look at our quality criteria from our systematic review in 2018, but sit down and make a list of those things with someone who is a researcher, and then look at your program and see what they are. But the short list would be a good system to track everyone who comes in, register and track them. A system to ask them their intention about the cycles, about avoiding or conceiving or in between at the beginning of each cycle, collecting their cycle records, collecting their charts, whether that's electronically or paper, so that you have a complete record of their charts and not just, you know what their charts are. If you have a good tracking to follow up, a copy of all their charts and intentions at the beginning of each cycle, that would get you about 90% of what you need.
bien, muchas gracias.
Thank you very much, Dr. Stanford. We've got several questions here. We should pool these questions because there is a lot of interest. There is interest, as for instance, as the question for Dr. Boyle from Guatemala. from Ecuador, they also ask. And there are a couple of things that are interesting. One question as well that comes from one of our colleagues in Peru. How do you cope in Ireland with the use of drugs that are within the protocols of neofertility, but that are not supported by the companies, that the drug studying companies, naltrexone, I think, and Adderall, I think he said. Is there any special regulation in those countries? And another question that arose as well, if that approach of neofertility is naprotechnology, or is it an approach that has some nuances to it? I think it's interesting to clarify it. It's also useful in order to go more into depth in the RRM. The president of the institute could go into depth in it.
Sure, I think there are two good questions, and maybe the first one, what's different between neofertility and naprotechnology? I would have worked in naprotechnology for almost 20 years before I branched out to neofertility. And the key thing with naprotechnology is you work with the Creighton model chart and you implement principles of restorative reproductive medicine through the Creighton model chart, and then it's naprotechnology. If you use any other kind of charting system, then it's no longer naprotechnology. It is what we would call generic restorative reproduction using different charts. So a lot of the techniques that I would have learned and evolved through Creighton model and naprotechnology, I implement those on a different charting system now. The other thing then regarding those unusual medications that are off-label use, as doctors, we use medications off-label all the time. So it's not unusual. How many doctors, for example, would use metformin for women with polycystic ovaries? That's off-label use. How many doctors would use hormonal contraceptives to treat the pain of endometriosis? That's off-label use. The list goes on. So if we're using medications that we feel clinically are likely to benefit our patient, even though the medication was licensed for something different, we can let the patient know, well, this is off-label use, it's licensed for something different. Another very common one we use is letrozole, and that's a treatment for preventing the spread of estrogen receptor sensitive breast cancers, but we give it to block estrogen to stimulate follicle development for ovulation induction. So, and that's very widely used now, and clinically for many women, it's a better treatment than the licensed drug, which is clomiphene. So I think there's, so long as we are straight and honest with our patients, most of the couples that I would see, I'd explain to them, well, we're using this in an off-label way. What we're doing is new, but look, here's your cycle. Here's where the problem is. I think this medication may help to solve it. Let's try it and see, does your cycle move from this current poor level into a healthy status as a result of our intervention? And if they can see they respond, then it makes sense to them. Let's keep going with this, and hopefully we'll get success. So I think dialogue with your patient, at least in Ireland, that's the most important thing. And thankfully, where we don't have the restriction of you can only prescribe what's licensed, or you can only prescribe what's proven through randomized controlled clinical trials. I think it's real important in medicine that we practice and we use our medical training in order to implement strategies that make physiological sense and that we're not restricted by protocols. So we don't have protocols, we have guides to allow the physician to judge, do I think that this particular treatment is reasonable for my particular patient?
Thank you.
Thank you very much, Dr. Boyle. And vamos a preguntarle ahora.
I'm going to ask for Dr. we have limited time, but we have questions for others. I think they are interesting. The first one, Dr. Donoso, in his experience, has been able to detect systemic conditions that have improved logically later on the health of the patients through the card, as they say, or the registry, as they say, or cartola, as they say in Chile, diabetes, hypothyroidism, anemia, etc. How is your experience in finding other pathologies through the reading of this registry? The second one, I'm going to ask them all together so that he then can answer them. The second one, how do the medicine students, the young ones, the impact of this training in women's health, the experience of men, and also the question that is an anecdote, but it's yet interesting, if the natural fertility awareness is useful in order to be able to choose the sex of the child or not. Well, fine. Pleasure to greet you, Luis. And I want to congratulate you as well, because you represent the University of Navarra that has made a great effort together with the whole rest of you and all of us who participate here, because in reality it has been a very good symposium. Well, the chronic diseases is a terrible challenge for us. And for us, obesity and what comes with it, that is often the anovulation, metabolic problems that have to do with the syndrome of polycystic ovary or insulin resistance that is coupled to it as well, have allowed that couples, women who have difficulties on this side, for instance, should be aware that this is affecting them in the reproductive health as well. And when they adopt measures as reducing their weight, they see that this has an impact, improves on her psyche. For us, it's very important that women with chronic diseases are aware. For us, obesity and in the States as well, the same thing is happening. In Europe, you have less rates of obesity, fortunately. But for us, it's very important that those women are aware, become aware of those problems. And we believe that the fertility registry has been of very great help in reaching that. I can forget many things as well. Hypothyroidism, the person who doesn't take the drug, when there is a hypothyroidism that is severe, very deep. Well, it has an influence as well on many other things in the woman. And she also sees that in her registry and many other conditions that I could think about. And this allows women with chronic diseases to be aware of the impact that what they do upon their life, etc., and their health is very good for adhering then to this problem. But as to the students in health, and the second question that you were asking me, we feel that we are seeding, so to speak, leaving the seeds there, and that seed can fall among stones, or it can fall in a fertile ground as well. And this seed can be that maybe it's not going to germinate now, but a little bit later, and we are leaving there the knowledge. And this is a tool that is very good. And for the future, the students are aware of it later on, and also in their personal daily life, how they are going to live their own fertility. We believe this is a seed that we don't know when it's going to germinate, but we believe it is very important to let it be there in the medicine students, so that each one of them is free to how to use this system. But this is there in their heart, and they can use it at least to say this is not good, this can be helpful, and it can be very good for you. And finally, if it's helpful to determine the sex of the child, we are many of us parents. Our experience, at least what we have seen in some papers, is that it is not helpful in order to determine the sex of the children. If the intercourse took place later after the ovulation allowed to the children to be girls and the other way around. What we have seen is that there were no relationship between the timing of the sexual relation and ovulation with the sex of the child. I don't know what's the experience of Phil or Joseph that also dedicates to this, but in our own experience, this is not so. I'm going to ask the organizers to give time for the translator to say everything I have said. Well, I have been saying it at the same time, otherwise it would be quite impossible. And we haven't access to the translation ourselves.
Well, they are receiving the translation. They are doing the translation at the same time. It's something called simultaneous translation. But anyway, unfortunately, no, you're not receiving? No, you're not? Oh, no? Why do you say no? Well, we have to finish here because the question has been very enriching. We've received lots of questions. And, well, these questions are then going to be, well, handed over to the speakers, as it were. And, well, these questions will be answered in the near future. So many thanks to our speakers, Dr. Stanford, Dr. Phil Boyle, Mr. Donoso, and it's always difficult to get together. And, well, we would love it, to have you all here, but of course, well, this does has its advantages because, well, he's in Quito, and that's interesting. But I think that there are things that we have been looking into in the world that actually have produced results, and I know that we're now planting seeds at the International Institute of Restorative Medicine. And there are people there that are concerned about implementing these techniques in their countries, and now they have a specific channel at their disposal. And what it allows them to do is to get in touch with doctors, and there are continuous training programs. But anyway, we at the University Andes and the University of Navarra have a workshop once a month. So we try to organize congresses or conferences too. So I would like to ask you people to feel motivated about what we're doing, and that we have to unite our forces in the future, because this is extremely interesting work, and it's definitely worthwhile. This has to do with the health of women and the health of couples. And, well, we want there to be a response that is anthropologically healthy and which improves the health of women. So thank you very much indeed for your participation. And, well, we are going to stop the session here. So thank you very much. Goodbye.